Hi, my name is Kyra Inskeep, and I am a nurse here at the Burn Center in Wichita, Kansas, and I'm going to go over burn wound management with you. In burn wound management, we're going to go over what it's like and what you need to do when you get this kind of burn into your either ER or if you're first on scene as a first responder, and how do we go about getting this burn taken care of while providing the best functionality for our patients. In this course, we're going to teach you about how to differentiate burn depths. What that means is partial versus full thickness burns and understanding principles of wound care. They are going to also understand indications for escharotomies on when we need to go in and do a little bit more aggressive surgical intervention. It's also how do we take care of some of those specialized areas, whether that's hands or face or feet? All of those areas kind of require some unique and differentiating different types of care. The first thing I want you guys to remember is when you have that big gnarly burn come into the ER or up to your unit, the first thing you need to do is remember your ABCs. The burn is not the primary immediate threat to that patient. It is going to be, is their airway secure? Are they breathing? And do they have good circulation? After you've addressed all of your primary things, then you can kind of go into the proper wound management of critical care and proper care management of those wounds. And how well that care happens and how much we are able to get in and take care of those things determines an individual's survival, as well as when they do survive, what their functionality is going to be after they've been healing. First thing is to remember that your skin has a couple of different functions. It protects you from infection and injury. It prevents loss of body fluids, regulates body temperature, and provides tactile senses. You have 4 different layers of your skin. You have epidermis, dermis, subdermal, fat, and muscle. So when we talk about burn depth, it's sometimes on a more of a continuum. It can be initially very difficult to assess because everything is just freshly angry. It's going to be red, it's going to be hot, it's going to have big feelings. And so as we continue to treat that patient, sometimes that burn depth will change. And as that depth changes, we will change their wound care needs. Burns that are of a deeper depth and require a little bit longer to heal are often best treated by just skin grafting. And then that depth also determines the functionality and the cosmetic outcome for that patient and their overall recovery from their burn injury. So when we talk about the physiological impact and how burns impact the rest of your body and all of the rest of your systems, it depends on 2 things. The temperature and the duration of exposure determines the depth of that burn, but the physiological impact to the person depends on the depth and the total body surface area of that burn. So if you have a deep burn covering over 20%, then you're going to have a significant physiological impact to the rest of the body, including whether that's impact on lungs or heart or kidneys. It will impact how the rest of the body is able to respond to that kind of injury. The first and most simplest kind of burn we're going to talk about is your first-degree burn. Often like your sunburns or a quick flash can give you a first-degree burn. They're painful, they're red, but the skin overall is still very intact, and these burns heal in a couple days with just some good old lotion and very minimal wound care. We do not calculate first-degree burns into our TBSAs because the skin is still intact, so you don't have that same physiological impact that you do when you start losing that epidermis. Your partial thickness burns or superficial second-degree burns are burns that expand over the entire epidermis and dermis that are injured. The skin may be red, blistered, wet, or weepy. These are often like your hot water burns, your scalds. They form blisters. They have good blood flow, but these burns hurt a lot because those nerve endings are damaged, but they are still very much intact. Deep second-degree burns are a little bit slower to blanch. Sometimes they're hemorrhagic in appearance, where those blood vessels have been damaged and kind of risen to the surface. They are often drier in appearance, and they're what's called slower to blanch. So if you push on that hand and you wait for a white spot to develop and then you take your finger away, how quickly does that blood flow return? Maybe it never even blanches to begin with because it's so hemorrhagic. Or maybe it's extremely slow to blanch because, the depth of that burn is deeper than what you would have expected, or deep enough to cause that slow blanching. Your healing of a second degree burn takes about 2 to 3 weeks. These are often not surgically intervened upon unless there is a reason to think that the burn healing is going to be delayed, or if going in and doing skin grafting is going to improve their overall function and cosmetic outcome, then they will go ahead and work on your second degree burns. Second degree burns heal by budding. So basically the tissue is still intact underneath to where it can start reproducing those skin cells and forming from the hair follicles and sweat glands. So you have a base there to start the reconstruction of your skin cells. Your full thickness burns, however, are a little bit different. These are often called your third degree burns. Um, and these are when your entire epidermis and dermis are involved. These often appear white and charred. Then we call them eschar. And if you think about leather, it's very similar to that appearance, where all of those blood vessels have just been coagulated. There's no capillary refill because the blood flow is no longer going to that area, and the pain is actually fairly minimal because those nerve endings just no longer exist. Whereas in your partial thickness burns, they have just been damaged. Third degree burns heal differently than second degree burns. Third degree burns heal by growing from the outside in. And that actually, when you heal like that, and if you think of like I'm trying to show you my elbow, if you heal from the outside in, it's going to pull that tissue together, often leading into complications such as scarring or contractures. The ultimate treatment for third degree burns is skin grafting. And once you get that third degree burn off of there, then you can start working on getting that tissue regenerated and start healing. We don't usually use the term fourth degree burns. It's more so just the deep tissue loss. And that means that injury involves the fat, the fascia, the muscle, the bone, the tendons. These are often very complex, and they require either multiple surgeries or amputations, couple of trips back and forth to the ER or the OR to get those cleaned up. So when your burn happens, usually what develops from that burn is considered the zone of injury. So if you look there, you can kind of see the 3 different layers. The first, on the most outer part of that burn, is your area of hyperemia, and that often is red. Sometimes we'll get a call from a provider saying, I think my burn's infected, because it has that redness on the outside of the burn. Infected burns very much present like your septic injuries with streaking, and that redness is infecting the entire extremity versus just around the center of the burn. The zone of hyperemia is where your blood vessels and your blood cells are going in to try to get that burn healed up. The zone of stasis is kind of that in-between area that sometimes it's going to heal or sometimes it's going to be a little bit deeper, but that is a healing zone, whereas the zone of necrosis has no ability to heal. That is dead tissue there, and area around that is going to start trying to pull closed to try to heal that burn up. Increased zone of necrosis or wound conversion. So when we go back to this picture here, let me go back. But if There's another one coming up. Here we go. That talks about wound conversion. So if you look at that picture on admission day, it is a very centralized third-degree burn in the middle of that burn. But by day 5 in the hospital, that whole burn is white. And that is a great example of wound conversion where that patient either was already in poor health, whether it was diabetes or vascular disease, um, or they did not receive enough nutrition, or infection is another good reason that wounds do end up converting. Um, as the burn affects the rest of your body, what we see is a fluid shift in that wound bed. Your body tries to heal itself by bringing all of the fluid to that area. When you have a burn that's greater than 20%, you start seeing significant fluid losses, and if it's untreated, it can lead to some severe hypovolemic shock. The inflammatory response that we see is very proportional to that wound size. Again, after 20%, you end up seeing more of that inflammatory response with severe edema affecting all of the body, just not around that burn area. The sequela of fluid accumulation is that edema formation that happens to the rest of the body. And in severe cases, it can impair blood flow. And it is really important to monitor your extremities or your compartments, anywhere that may have a burn that is circumferential, and may limit that blood flow to either the extremity, or in this man's case, it restricted his ventilation because the burn is so tight that they actually will have to go in and do the escharotomies to relieve some of that constriction and let him breathe better. So if you are a pre-hospital provider, one of the biggest questions is, what do we need to do for that burn as soon as we see it? Is after your ABCs, of course, you're going to stop that burning process. So what that means for us is taking off any rings or watches, anything that may contain heat. With babies that come in with diapers, if it's a scald burn especially, sometimes that diaper can hold in hot water and make that burn continuing to be worse. We don't recommend ever cooling a burn. You can use room temperature water, but when you start cooling the burn, you start causing those blood vessels to get tinier and tinier, and the lack of blood supply will make that burn worse. So really, we just want you to try to keep them as warm or normothermic as possible, with the ultimate goal being to prevent hypothermia and keeping them clean and dry. So if you just need to wrap them up in a warm blanket and send them, then that is completely appropriate. When they are in the hospital, there's a couple different things you can do if you're not in an ABA's referral. And you can always call your local burn center, and a lot of times they'll be able to set you up with a treatment strategy. But sometimes a patient needs to come to us, and so there's either a delay in care because of weather or transportation, or in the event of a big disaster. Even if you're not an ABA hospital, then you will be responsible for that wound care. And so again, it's always best just to consult with your burn center on how you would further like to treat that patient. Some principles of wound care is one of the things that you find most in your burns is that infection. So we wash everything with soap and water. If you use chlorhexidine on a burn, it will sting. It will hurt quite a bit. You can use it everywhere else, but on that burn, it will hurt. If a blister is less than 2 centimeters, I usually use the guise of a quarter. If it's less than a quarter, then we don't pop it. That's nature's natural Band-Aid there, so we're just going to leave it alone. If it's greater than that 2 centimeters, we're going to debride it. We're going to take off that head of that blister and pull back the skin just to make sure the skin underneath is indeed something that's going to be easily managed or healed up with a topical dressing. Second-degree burns in particular, sometimes we can use multi-day dressings that are embedded with silver, and that kind of helps keep that infection at bay and provide some antimicrobial protection. The types of dressings and topical things that we use depend completely on what is that burn. The goal of all burns is to decrease that colonization of antimicrobials and delay the infection. So often we use something like bacitracin on your second-degree burns. If it's something deeper where you need to kind of get in and clean up some of that dead tissue, we have other medications. Most commonly is SSD or sulfadiazine, that we will use on some of those burns that are a little bit deeper and need that cleaning. Again, but the silver in that medication helps, and the sulfa helps provide that infection prevention. We will apply that dressing with a primary dressing, and then we'll use a secondary dressing like gauze and ACE to kind of fixate that dressing into place and make sure it stays where it needs to be and it doesn't move and is able to do its job in healing up that burn. When we talk about escharotomies, it is something that happens when we see circumferential burns, whether that's over an extremity or over the abdomen and chest. What we see is as we are doing our fluid resuscitation and those burns are becoming more and more third degree and having less elasticityism, is that it can create a tourniquet effect. And so the swelling that's going to be happening because of that the sequela of fluid, your body's rushing all of your inflammatory mediators to try to heal itself, can actually end up reducing blood flow. We usually do not recommend pre-hospital providers doing escharotomies. If it is something, again, that you feel like it needs to happen, it's usually best to consult with a burn surgeon first, and they can kind of give you some pointers on how best to go about doing an escharotomy and not damaging the burn or other options that might be available besides doing the escharotomy. The actual procedure for the escharotomy goes along only the area of full thickness, and it goes through that eschar layer. It does not cut into the fat or fascia, and you don't do this on your partial thickness burns. You are looking for that tight white skin that doesn't have any elasticity left in it, and you're starting to recognize that the patient is having poorer perfusion in that extremity. To help negate the need for escharotomies, we'll do things like putting their arms up on pillows, so that way, the circulation, gravity kind of helps you out a little bit with that fluid. The actual definition of a compartment syndrome is that elevated pressure in that anatomical space that impairs your circulation. Sometimes fasciotomies are required over escharotomies, depending on how deep down in the damage done by that burn. There's several risks associated with compartment syndrome and having to get escharotomies, including you're at risk for needing escharotomies if you're having to have that massive fluid resuscitation. Some of your high voltage electrical injuries where you definitely have this huge surge of fluids, and those tend to be a lot deeper burns. We also cannot always see the results of electricity as it passes through the body. And then delaying in escharotomies also can lead to amputations and loss of function. How do you know it's time to do an escharotomy or a fasciotomy? Well, you're going to be continually evaluating that arm. You're going to be looking at the skin pallor, cyanosis, the deep tissue. Is it the paresthesia? Do they have sensation? Are they still able to move their arms? Is there a decreased capillary refill? And then the very late sign is the loss of pulse. What we do here in the burn center is we will put oxygen saturation probes on those extremities to monitor that we are not going to lose a pulse or that we are still having perfusion to that area. Face burns present a little bit more of a complicated situation. Extensive face burns really will have an edema portion, and that will compromise your airway. The swelling that's happening on the face is also probably happening internally. And so getting those patients intubated fairly quickly is going to save you a lot of headache down the road when they start to swell. It will also kind of allow you to evaluate that respiratory tract for damage that's caused from their injury. So if you are in a smoky building, did you inhale any soot and smoke? Do you have some kind of inhalation degree to it, or is it, do we need to be concerned for additional swelling from that injury? Facial scarring can happen. Usually, faces end up healing fairly well. They have good blood supply, but um, it can cause some significant psychological impact with some of your facial scarring. With a face burn, you're going to assess your airway. You're going to keep your head elevated to help keep that fluid down lower. You're going to secure your tubes and lines, and you're going to protect the ears and eyes. What does that look like? Well, for your eyes, it's pretty early to jump in and start examining those guys. You definitely want to get in and remove any contact lenses. Use a fluorescein light to identify any corneal injuries. You're going to irrigate chemicals with saline, and you can provide some mild ophthalmic to help with that eyelid edema. We do encourage you to avoid steroid solutions. The other thing, if we are concerned, we will also go ahead and just consult an ophthalmologist. And we are lucky here that we will have somebody come in from outside to evaluate eye burns and give us some recommendations on how to get our friends healed up. Ear burns, similarly, when you have your patient come in with those facial burns, taking a peek in their ears will kind of help you assess for damage to the ear canal, as well as any chance of tympanic membrane perforation. You see those most often in your blast injuries, where there's been a huge pressure change and that person received a burn, but also you're looking for additional injuries. We try to keep pillows away from those ears. We have what's called moon pillows here that are kind of shape shifting. And then we don't put occlusive dressings on ears because if you can hear, that is lovely. And if we cover your ear up, then you won't be able to. With your hand burns, you're going to elevate those guys, and then you're going to do your frequent neurovascular checks. With our hand burns, we work really hard on maintaining that functional recovery. So getting physical therapy and occupational therapy in particular in early to start doing the stretches and doing the hard work is essential in getting those hands to heal up and preventing permanent loss of function. Your foot burns, kind of the same thing. You're going to elevate them if they are burned. You're going to be reassessing them frequently for pulses and pallor and pain. You're not going to put on constricting dressings. And you're going to be aware that your foot burns in particular are going to have complications, especially in your neuropathy patients or your diabetics or your friends with your poor blood flow. Those foot burns tend to heal a lot slower than for your normal patients. When it comes to genitalia and perineum burns, the first thing we would ask you to do would be to insert a Foley, because once all of that starts swelling, it's really hard to monitor that urine output or get that Foley in. But we do want you to call a burn center if it's involving full thickness to the genitalia. Tar and asphalt burns. Fairly common. It's a contact burn. Tar has a high viscosity and a high temperature, and then it cools immediately. Its removal is not an emergency because it does cool immediately. So removal is done once they are actually in the burn center. And fun fact, one of the easiest ways we get tar off is with the use of mayonnaise. So just to kind of summarize what we've gone through, wounds secondary to airway and other life-threatening priorities. We always want you to go through your ABCs and your primary surveys first before deciding what you're going to do with that wound. Secondly, we want you to remove anything that might be continuing to heat that burn. Burn depth is what dictates your whole wound care strategy. Our goal of all of our wound care is maintaining functionality and continuing to keep it cosmetically appealing. It is a big, huge life change. And so whether that's scar management or multiple surgeries to kind of continue to keep that functionality. We reviewed escharotomies and why they are important in preventing compartment syndrome, and kind of just reviewed some of those important areas that if you notice on your hands, your feet, your genitalia, your face, those are all good reasons to get that person to a burn center so they can get that specialized care.